First Lady of Foxy.
Yeah.
I'm not here as First Lady.
Not here, but you are still.
Ma'am is not here as First Lady, ma'am.
ma'am.
So introduction is not like that.
Oh, no, I'm just joking. Yeah, thank you.
Hello, very good afternoon, all of you. We are live now. So I welcome all the faculties who are here together for an eco webinar series, which was scheduled on today for 29 January. To start this session, I would like to first start it with the prayer.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
So first, I would like to introduce our first conveyor, Dr. Monica, who is a consultant ops and gyne doctor. She's a national coordinator of PAC committee of 23-25 and also a Zoom
Prerak,
coordinator.
I will take it from here. Yes, thank you so much, Prerak.
Okay.
Yeah, thank you. So,
Shatabdi, yeah. Good morning. Good evening. Sorry, joined a little late.
episode of this.
Hi, Monica.
Yes,
Yeah,
Monica, yes, over to you. She is the current chairperson of the Public Awareness Committee. Over to her.
Please stop sharing the slides. A very warm welcome to the 10th episode of the Eco Webinar series. The program director of this Eco Webinar series is none other than Dr. Kalyan Baramde, sir. Sir also has been the past chairperson of the Public Awareness Committee, and currently he is the president of IAGE. And these webinars are focused webinars where we have only one lecture followed by a panel discussion on a particular topic, so that we enhance the care by reaching the rural outcomes. So this program is the brainchild of Dr. Kalyan Baramde. And today we are having the 10th episode. We do it every 15 days with respective zones. We have Dr. Muralidhar Pai, sir, as our esteemed faculty member today, who will be speaking about the instrumental deliveries, followed by a panel discussion. It will be moderated by Dr. Kalyan Baramde, sir. Can we have the inauguration slide, please? We seek blessings from Lord Almighty. And then I would formally request Dr. Kalyan Baramde to welcome the August gathering after the inauguration.
We are done with this, Monica.
तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
फोटो भी तो शेयर नहीं करते हैं लोग.
Hello?
Yeah, please go ahead.
Yes, Dr.
Yes, Monica.
Monica, you are muted.
Yeah. I request Dr. Kalyan Baramde, sir, to please welcome the August gathering and introduce our chief guest for today.
Good evening, everyone. On behalf of Eco Webinar Series, that is enhancing care for healthy outcomes, I extend a warm welcome to all esteemed faculty, participants, and society representatives who are joining us today. We are privileged to have a chief guest with us, Dr. Pragya Mishra Chaudhary, who is the Secretary General of ISOBAB, and our guest of honors, Dr. Sitapal, past chair of Genetics and Fetal Medicine Committee, Dr. Suman Sinha, who is the chairperson of Vaginal Surgeries Committee. We are truly grateful for your presence and support. This evening, we are delighted to have active participation from several distinguished OBGYN societies like Patna, Gangtok, Dhanbad, Durgapur, and Ranchi OBGYN societies. I thank all president and secretaries of these societies for joining. We are honored to have the presidents, office bearers, and senior members of these societies who have joined us today. We also warmly welcome Speaker of the session, Dr. Murlidhar Paisar, who is the Dean of Sikkim Manipal Institute, and he is going to talk on can revival of instrumental delivery reduce the cesarean section rate. That is very important topics of today pertaining to the increased cesarean section rate of today. Also, we like to specially acknowledge our chairpersons for the scientific session, Dr. Hafizur Rahman, Dr. Priyanku Roy, and Dr. Dipanvita Sen. We deeply appreciate your guidance and support for today's webinar. We also warmly welcome all our panelists for the session. We are going to have a panel discussion featuring distinguished panel of 8 experienced experts and clinicians from the East Zone. Thank you each and everyone for being here and contributing for this academic initiative. We look forward for enriching session and meaningful discussion ahead. I thank Dr. Monica Umbardand and Dr. Satabdi Dey, who are the main pillars behind this webinar series. I thank them from bottom of heart. I now request to put Dr. Pragya Mishra Madam's CV for her introduction. Dr. Pragya Mishra Madam, who is MRCOG, FRCOG, and Diploma in Gynec Endoscopy from Kiel, Germany, who is a consultant in fertility and IVF specialist at New Life Test Tube Baby Center, MGM Hospital and Research Center at Patna. She is presently Secretary of ISOBAB and Chairperson of Genetic Fetal Medicine Committee from FOXI 2016 to 2018, Founder Secretary of Bihar Chapter of ISAR, Vice President of Patna OBGYN Society 21-22, Secretary Patna OBGYN Society 2019 to 22. She has been awarded a lot of awards and has contributed many chapters in the book, and she's been organizing secretary of many of the Bihar OBGYN conferences. So I request Dr. Pragya Mishra ma'am to say a few words for blessing this webinar.
A very good evening.
Yes, ma'am, you're audible.
I think it's echoing.
You need to
Yeah,
switch
yeah.
off your mobile, ma'am, because the voice is echoing. You are logging from two centers.
A very good evening to all of you. At the outset, I would like to thank Dr. Kalyan Barmade for conferring this honor to me, inviting me as the chief guest for your series, which seems to be becoming quite popular. And I like the name ECHO, which is enhancing care for healthy outcomes. So outcomes. I don't know from how did that strike you, but it is indeed a very pleasant terminology. This ECHO, the series which you have, webinar series which you have started with. Well, I have known Dr. Kalyan Barmade since very long, when he was the chairperson of Public Awareness Committee, and he was indeed a very, very dynamic chairperson. And that time I was the secretary of Patna Obs and Gynae Society, and currently I'm the president. Just to correct, I'm the president of POGS. The two conveners of the program, Dr. Shatabdi Dey and Dr. Monica Umbardand, who have been really working hard to make the series successful. And at the outset, I would like to thank Monica for just being installed as the chairperson of Public Awareness Committee. And the two guests of honors, I just said, Sita is I would still love to call you as the first lady of FOXI at present, which indeed you are. And the other guest of honor, Dr. Suman Sinha, who is a friend also, and she's chairperson of Vaginal Surgery Committee of FOXI. And the best part is that, Dr. Kalyan has been able to bring such academic people, all on the same platform. I can see Dr. Priyankur, who's the past chairperson of Public Awareness Committee, and Dr. Hafizur Rahman, a very, very popular person in the ICOG Governing Council, and I'm very sure near future, very soon he would become the secretary also of ICOG. I'm quite confident about it. And other stalwarts, who are such great speakers like Dr. Muralidhar Pai and Dipanvita again is such a highly academic person. I've had interacted with her so much in the past because of colposcopy workshops and all that. And so really, Dr. Kalyan, I'm sure you are going to embark upon, you have thought about embarking upon something new, and that's why you've taken upon this webinar series. And I'm pretty confident that you would be successful in your next endeavor, because at such a young age you are the president of IAGE. That in itself, one wonders, like, how this small head can carry so much. So, and definitely you're going to go very high, perhaps even in Foxy also. And I'm really looking forward to this panel discussion, which I'm going to moderate. And it's also quite pleasant to see the names which are there in the panel, because I think from the East zones, you've tried to collect the secretaries and some quite eminent people also from the East zone. And I wish all success to this program, and I'm sure you're going to keep on doing it for the next 1 year or so. And congratulations and best of luck, and hoping that I've not missed out on anyone. Definitely, like Corona is always there, to support us for all these programs at a very short notice. And keep up the good work, Shatabdi, with your, I know you're the national coordinator now, the new one for Public Awareness Committee. So keep up the good work. And Monica, definitely, we've already seen what she has been doing for public awareness, and she's going to do wonderful work in the next 3 years. I'm pretty confident. So, thank you so much for having invited me once again. And I would just say that, because instrumental, it's quite, actually, I was quite surprised that Dr. Kalyan Barmade, who is mostly an endoscopy person, and he has taken up this topic of instrumental deliveries, which perhaps I think you might be interested in obstetrics also. And it is like almost being considered a dying art, just like breech vaginal delivery. So it's something, we need to revive, and we need to see the resurgence of instrumental deliveries. The problem is that, every now and then in different platforms, some people will stand up and say, oh, cesarean section is such a safe procedure these days. Why not do a cesarean section without any injury to the perineum? And women are also requesting for cesarean section. So sometimes, even very highly eminent people also, they bring up things like this. So then juniors also think, oh, why not I do a cesarean section in 30-35 minutes? Why should I learn the art of instrumental deliveries? But I think cesarean section, we all know that there is a rising incidence of placenta previa, placenta accreta syndrome, and especially, women coming from peripheries with rupture uterus. Like we have seen so many cases of rupture uterus coming from periphery in the peripheral areas from Bihar. So, and it's quite sad, and they end up with secondary subfertility, and they never even conceive. Previous IUDs, and with cesarean section, they have been delivered through cesarean sections, ended up with secondary infertility with quite a gloomy outcome also. So, so really, it's something, I think instrumental deliveries, I think all of us should, the ones who are already doing well and good, they can just refresh their knowledge, and the ones who are not doing, perhaps they can go take away some good take home messages and tips out of today's program. So keep up the good work, Dr. Kalyan, and I think a bit of gynecology and obstetrics also, other than endoscopy, that you have brought into your webinar series.
Thank you, ma'am. We are focusing mainly all OBGYN. This is the 10th episode. We are going to conduct around 40 episodes in the coming year. And I'm
That's
really
great.
thankful to you because we have been to AIIMS Patna twice in last 1 year. And both of these conferences were super successful because of the involvement of all Patna team and leaders like you. I thank you from bottom of my heart. Thank you so much, ma'am. Dr. Monica next.
Thank you, Pragya ma'am, for gracing the occasion. It is an honor to have you on this platform with us. And now it is my proud privilege to introduce our guest of honor, Dr. Sita Ramurthy Pal, madam. Madam is a consultant fetal medicine and obstetrician from Apollo Multi-Speciality Hospital in Ankura, IVF. This is the formal introduction, but she has been the past chairperson of the Fetal Medicine Committee and the Joint Secretary of Bengal OBGYN Society. She has also been the President of Society of Fetal Medicine in Kolkata, and she is a fellow
Monica, that will be
representative of
fine.
RCOG.
Thank
Ma'am,
you.
over to you for your words of wisdom.
Thank you, Monica, for
The
the
First
kind
Lady
words.
of Foxy, ma'am.
Thank you so much. I thank you for that honor. It's indeed my privilege and honor to be the guest of honor for this wonderful eco series, and I congratulate Dr. Kalyan Barmade, our dear friend, for the 10th episode. It's indeed, I echo Dr. Pragya Mishra's words that it's a very catchy term of eco, enhancing healthcare outcomes, and it's indeed a privilege to see and so to see it going on to the 10th episode, and wishing you success for furthermore. And I bring greetings from Kolkata to Pragya Mishra ma'am, Dr. Muralidhar Pai. You have a wonderful faculty who will be giving a talk. My co-chairperson, Dr. Suman Sinha. Congratulations to Monica as well for taking over the post, and you all have been guiding her immensely well. Priyankur, Hafizur, and Deepanita, who are all there. So it's a wonderful team to see from the East, and I really wish Kalyan all the best for his future endeavors, and I'm sure he'll do very well as he has been doing in his presidency for IAG. And bringing it to greater heights. Thank you so much. And as we were talking about instrumental delivery, I think it's a very important topic to be reconsidered because it is something that is still dependent, people are doing defensive obstetrics and it is highly regulated and that's why we shouldn't think that we should abandon it. I think it calls for better training, better ultrasound involvement. And I think that is what we're going to learn in this webinar with case-based discussions, how we can revive it and not be completely throw it out of the window. And I wish all the best for this webinar and the future webinars. And thank you once again for giving me this opportunity. Thank you. Thank you so much.
Thank you, Sita ma'am. You have a vast experience of working in UK, where this art is still there. And we are the one who started this act with KM Hospital, Vadea Hospital, Purandares, everybody. But now it seems to be fading in India, and it is much popular in European countries, and UK still dead. Though USA is increasing LSCS rate like India, but other countries are following it. So Dr. Muralidhar Pai sir is going to give us guidelines how to increase the operative delivery intervention and in which cases it is going to be feasible and how a training process should follow up. Thank you, ma'am, for your words of blessing.
Looking forward to the talk and the panel. Thank you once again. Thank you.
Thank you, ma'am. Now we introduce our next guest of honor, Dr. Suman Sinha, madam. She is currently the chairperson of the Vaginal Surgery Committee, FOXY. She's been a member of the Research and Good Practice Committee of SAFOC. She's a senior consultant at AHIVF and Infertility Center at Ranchi and at the Global Synergy Hospital. She's also been the vice president of SOSI Bihar and the Jharkhand chapter since 2021 and the past president of the Ranchi OBGYN Society. She's also the founder president of ISOPAP Ranchi chapter. We welcome you, ma'am, and over to you for your words of wisdom.
Thank you, dear Monica, for the very generous introduction. I really feel honored and it's a great pleasure to be a part of this very enriching webinar series, which has a very catchy name, as Dr. Sita has already said. It's ECO, enriching webinar on Eco webinar series. And for this, I congratulate Dr. Kalyan Barmade sir with his team for thinking of such a nice topic, because, and this is for the enhancing care for healthy,
Outcomes.
for healthcare of our women, I can say. And I would like to welcome our chief guest, Dr. Pragya Misra, who is also a very good friend of mine, and my co-chairperson, Dr. Sita Ramamurthy Pal. And Dr. Kalyan, you have selected a very enlightening topic, and it's a need of the hour, I can say, because everybody is running after cesarean section, and which they don't understand how what is going to be the result of that in coming future years, because most of the cases will land with placenta accreta, placenta percreta, things like that, which is going to be a very, I mean, we can have very difficult surgeries after that, and we can have more women dying of this procedure of ours which we are following. So I think instrumental delivery should come and it should be learned by each one of us once again, that is revisiting the art of instrumental delivery. And with this webinar, which you are going to take, I think, in all the societies of our FOXI, and people will understand the problem, the situation of ours, and they will revert back to this, which is not very difficult to learn. It's very easy, just you have to practice for it. And I wish great success of Dr. Kalyan Barmade. I wish you all best of luck. I know you are in something, you're going to achieve something with this. And also Satabdi is not here. I also wish her good luck. Dr. Satabdi is also
Ma'am, I'm there.
Where are you? For
I'm
you,
there.
also my best wishes to you. And the faculties, Dr. Muralidhar Pai, I really feel, I always, I'm crazy listening to Dr. Muralidhar Pai, his talk, and as well as his singing. I'm fond of you. And Priyankur and others, Hafizur, all are my friend. And this time the flight has taken from the societies of Eastern Zone. So from the societies of East Zone, I think we welcome and wish you all good luck. So thank you very much for including me in this webinar.
Thank you, ma'am. Also, the problem of ischemosal is increasing with the increase in the cesarean
Yes,
section rate.
yeah, that was, yeah.
Yeah,
So
and
later
so we have Dr. Muralidhar sir, who is going to guide us and give us guidelines how to go about in your clinical practice, which are the cases where you can at least try outlet and other forceps. And
a little bit of practice is needed to refresh ourselves, and then definitely we can do it.
Yes, ma'am. Yes. Thank you so much, ma'am. And thank you for your words of blessing. And we are really thankful to all E-Zone societies for participating actively. Kindly share in your local OBGYN society group so that lectures by Dr. Muralidhar Pai will be very good and will be enriching for all practicing OBGYNs. Thank you, ma'am.
Thank you, sir.
Thank you.
Thank you, Suman ma'am and Sita ma'am. Thank you, Pragya madam. Sir, with your permission, can we declare
Yes,
that the
ma'am.
inauguration is now over and we move forward to the academic session? But before, just a request from our side, please do support Dr. Kalyan Baramde sir in all his FOXI future endeavors, requesting all the East Zone societies for the same. And I would now request Dr. Shatabdi to please conduct the first scientific session.
Thank you, Monica. Once again, thank you to Pragya ma'am, Sita ma'am, and
Thank
ma'am.
you, Shatabdi.
Since our introductions, thank you so much, ma'am. Thank you for being there. We will proceed with our talk, very much awaited talk. Muralidhar sir's talks are always very, very enriching. So our talk, a topic for the talk today is, can revival of instrumental delivery reduce the rate of cesarean sections? The speaker is Dr. Muralidhar Pai, and we have Dr. Hafizur Rahman, Dr. Priyankur Roy, and Dr. Deepanita Sen ma'am as our chairpersons. Can I have the CVs of Dr. Hafizur, please? Dr. Hafizur Rahman is one of the senior consultants in OBGY in Gangtok as well as in Siliguri. He's the professor of Obs and Gynae. He was at Sikkim Manipal. He's also the governing council member of the ICOG. He has over 60 scientific research publications in various reputed journals. Welcome, Dr. Hafizur.
Thank you.
Our next chairperson is Dr. Priyankur Roy. He is the past chairperson of the Public Awareness Committee of FOXI. He has various research articles, and he's published various books in various chapters in various books. Welcome, Dr. Priyankur.
Thank you.
Our next chairperson is Dr. Deepanita Sen, ma'am. Can I have the CV, please? Ma'am is one of the senior consultants at Durgapur, at the Mission Hospital at Durgapur. She is the president of the Durgapur Obs-Gynae Society, and her special interests are in high-risk pregnancy as well as in minimal access surgery. Welcome, Deepanita, ma'am. Can we have Muralidhar Pai sir CV now? I will request Dr. Priyankur to kindly introduce our speaker for the day, Dr. Muralidhar Pai sir.
Thank you, Shatabdi. It's indeed a pleasure to be part of this ECHO webinar series, which is, of course, whose convener is, of course, my elder brother, Dr. Kalyan Barmade. Dr. Kalyan has been instrumental in bringing me into FOXI. He has given me a lot of opportunities and the platform as the, like when I was going for the PSC committee chair. And it's almost like 3 years are over, and I'm very happily I handed it over to Monica now, who I'm sure is going to do great work as well. So Kalyan Bhaiya, all the best for your election. I'm sure you're going to get elected as the Vice President from the West Zone in the coming year, and it's going to be wonderful for all of us as well. So now coming to the scientific session, Dr. Muralidhar Pai sir, of course, someone we love listening to. He is the Dean of the Sikkim Manipal Institute of Medical Sciences in Sikkim. He's been a professor of OBGYN, always a great teacher and always someone whom we have learned a lot from. Unofficially or officially as well, he's a great singer and we love listening to his songs as well. He has delivered more than 500 guest lectures, more than 200 publications, and he's the editor of the Jeff Cott's Principles of Gynecology, which is a wonderful book followed and read by many of us. So it's a pleasure to welcome you, sir, to this platform, and we are going to learn a lot from you from this topic on instrumental deliveries. And Dr. Kalyan, once again, wish you all the best from all of us in the East Zone, and I'm sure we are all going to be with you. Thank you.
Thank you, Priyankur, and I thank all the East Zone members and the First Lady of FOXI, Dr. Sita, Dr. Shatabdi, who called me and fixed this particular talk of mine, Hafizur, who is a good former colleague and a good friend, Dr. Monica, Dr. Sinha, Dr. all of you are good friends. And let me straight away get into the topic now. Can I please share my slide? Can you just remove this? Yeah, thank you. I think that was a slightly older slide of my introduction. So this is a newer slide of introduction. Okay. Well, let me now jump into the topic. The question posed to me is that, can revival of instrumental vaginal delivery reduce cesarean section? Well, if you want a short answer from me, the short answer is yes. But then, before you say yes or no, you have to really think hard. So I would make a prudent answer. What is the prudent answer? Potentially yes. Now, what is the meaning of this? Potentially yes. Yes, it has got a lot of potential, but it has to be tapped. As everybody said before the start of this webinar, the instrumental delivery is now becoming a dying art, especially in our country as well as in United States and most of the other countries, except maybe in the European countries, it is still existing. So it has a lot of potential to actually reduce the rate of cesarean section. That's why my prudent answer is potentially yes. But what is the smart answer? Because, these questions, you cannot just answer in yes or no. That's why I'm putting so many answers. The smart answer is reviving, but optimizing. The word I'm using is optimizing, because we should not be simply biased. There are many people who are now either biased towards cesarean section or bias towards vaginal delivery. In fact, I have seen some advertisements in our hospital, 70% of deliveries are the vaginal deliveries and things like that. This shows a clear bias and a clear misguiding of the patients. Nobody can promise, a vaginal delivery. At the same time, jumping into cesarean section for all the cases is also wrong. We have to optimize the use of instrumental vaginal delivery. That might help reduce the cesarean section rates, especially the primary cesarean section rates. I don't want to get into the Robson's criteria, but what we are trying to avoid is a primary cesarean section. The secondary cesarean section, of course, has got a lot of other confounding factors. And the sections done for malpresentations, it has got its own reasons, where instrumental delivery has got very limited role. But what we are talking about, a primary cesarean section in a cephalic presentation, whether it can be avoided by the judicious or optimal use of an instrumental delivery. But the evidence is nuanced and not straightforward. I really went into the depths of trying to find out whether there has been any concrete study or a randomized control study done in this aspect. Unfortunately, I didn't find any. Most of them were observational studies. Most of them were opinions. Most of them were just, experiences or the practicing tips that has been there in the literature. But however, let me try to make a justification for the case for instrumental vaginal delivery. But it's not justification. I would rather put it as a proper knowledge or a proper utilization of the instruments, which is very important. The reduction should be considered as a bonus. That should not be considered as an aim. Because as I said, if you want to hook or crook bring down the cesarean section rate by doing vaginal delivery or instrumental vaginal delivery, there are chances that you may burn out, you may burn your fingers early, and then it will be 100% cesarean section subsequently. So we should be open-minded. We should be more scientific in our approach. We should be judicious in our approach. We should be more prudent in our approach. This is the biggest disclaimer I'm giving before I get into the actual substance. So what is the better answer? You know the quick answer, yes. You know the slightly better answer, that was the potential, yes. But now, what is the actual or scientific or better answer? Before I get into better answer, let me explain the indications and present the evidence for you before I spell out what is the correct answer for the question that has been posed to me. All of us know this very, very straightforward. This is undergraduate level actually, but still it is very important to rethink about it. What are the indications basically for an instrumental vaginal delivery? Most of the time, we always think of instrumental delivery when the baby is already very low in the birth canal, because the high forceps, high vacuum delivery is totally obsolete in modern obstetrics. What we are talking is below zero station. In fact, at the max, we are talking about +3 and +2 station. Above that, it is better not to use the instruments. So when the baby is very low in the birth canal, but the progress is stalled for some reason, maybe it's a case of occipito-posterior, where it takes a lot of time to rotate, or maybe it's more serious than that, a missed cephalopelvic disproportion, or it could be a just contraction at the outlet, which is extremely rare, but it is possible, a coning of the pelvis, wherein the baby finds it difficult to rotate and it gets stuck. So that is definitely the most common indication for the instrumental delivery. As I said just now, incomplete rotation in a case of posterior occipital posterior, or failure of secondary power. We all know there are two powers. One is the primary power that is given by the uterus, which is involuntary power to push the baby down. And because of that power alone, and because of the configuration of the pelvis, the head rotates automatically. So two drivers of the rotation are, number one, the configuration of the pelvis itself, as well as the primary power that is given by the uterus. Now, in addition to that, the mother also has to strain, which we call secondary power. Whenever she gets an urge to push, when the head compresses on the rectum, she has an urge to push. This will give additional power for the baby to come down and get delivered. If there is a failure of this, again, she needs a help in the form of instrumental delivery. So basically, these two are the important indications for a vaginal instrumental delivery. The second one, probably from the baby side, if you see, the fetal distress, which occurs very late in second stage. Now, baby has come down so low, and the baby's fetal heart rate either is variable or it just drops down. Now, to take her for cesarean section will, in any best setup, in Manipal, we have cesarean section next door. We have anesthetists on the call. We have neonatologists on the call. In spite of all that, it will take a minimum of 10 to 15 minutes before we put the incision. So in that time, if you can quickly hasten the delivery using an instrument, vacuum or forceps, in spite of having fetal distress, we can get a healthy baby, which can be resuscitated quickly, and we can avoid a primary cesarean section. So these are very, very common indications, whether it is forceps or vacuum. Then, of course, the other one is mother is simply exhausted. The baby is rotating completely. It has come down very much up to, let's say, +3 also. There's no distress, but mother simply cannot bear down. She's exhausted totally. Now, she may be asking for cesarean section at this time also. We should not at least get impatient. We should not err at this level. We can use a simple vacuum, maybe a Silastic cup in this case also helps, which is very, very simple and straightforward delivery. Or even a Kiwi's cup will help. You don't even have to use a rigid cup, metallic cup. You don't even have to use a forceps. Of course, whether it is vacuum or forceps, it depends upon the obstetrician's skill. Some people still prefer forceps because in vacuum, it is said that maternal effort is definitely required somehow, because you cannot be pulling so much using the vacuum. You can rely on the vacuum totally. Whereas in forceps delivery, maternal effort required is 0. 100% of the effort can be from the obstetrician. That's why those who are well versed with forceps, they would prefer forceps delivery. And outlet forceps, it's just a extension of the head that is all required. You don't even have to pull the baby down. Even if the baby is slightly higher at, let's say, +2 station, you can use a low cavity forceps, wherein you require two things. One is bring down the baby a little bit and then use the extension traction. So this can be the indication in some patients. But now I further bifurcate between forceps and vacuum. What I told in the previous slide is a general indication, whether it is vacuum or forceps. I called it as IVD, that is instrumental vaginal delivery. But are there any specific indications for forceps delivery? Yes. In fact, instead of saying this way, are there any contraindications for forceps? Actually, I found that virtually there is no contraindication for forceps at all. I'm not talking about the mid-cavity or rotational forceps, which are now almost become obsolete. There are some obstetricians like, Dr. Piley, sir, he still wants to revive rotational forceps. Barring that, most of us have given up the Killand forceps or the rotational forceps and even mid-cavity forceps, where we used to have a traction rod and all that. I'm talking about basically the outlet forceps and the low cavity forceps. Virtually, there is no contraindication. In fact, wherever there is contraindication for vacuum, you can still use the forceps. So that's why, if at all you want to master an instrumental delivery, it is better to master the forceps delivery. So you become a true master. Vacuum delivery is for the beginners as well as for anybody and everybody, but forceps is slightly a little more skill required. So it is better to master that skill on a mannequin. I'm not talking about prophylactic forceps, which we use as far as reducing the cesarean rate is concerned. Here, the forceps is used basically to reduce the stress on the mother, whether it's a case of preeclampsia or a heart disease or previous cesarean section and preterm delivery. Preterm delivery, we use forceps basically not for the mother, but to reduce the intraventricular hemorrhage that can happen if the baby suddenly pops up its head. So in this situation, the forceps is not to reduce the cesarean section, but it is basically to help the mother who is otherwise meant for a vaginal delivery only. There are no other problems, issues as such, but to reduce the general stress. Otherwise the BP may shoot up, heart disease, she may go for a cardiac failure. Previous cesarean section, she may have a ruptured uterus if she strains a lot. So let us not talk about this as far as reducing the cesarean is concerned. What is important to understand is that the indicated forceps, if you use this forceps, probably you are going to reduce the incidence of cesarean deliveries. Number one, as I said in the previous slide, most of the time it is the delay in the second stage from the mother's side, maybe because of the loss of primary or secondary powers. Sometimes suddenly uterus can go into relaxation. You can use, if there are no CPDs, if there are no problems of rotation, you can start a small drip of oxytocin and use the forceps and complete the delivery. Maternal exhaustion, I've talked enough. So it is required definitely to help the mother. As I said, if the mother is exhausted, the better instrument is forceps than the vacuum. In vacuum, you still need some maternal efforts. The biggest advantage of vacuum is auto rotation. As you pull down the baby rotates automatically, provided there is space for rotation. But maternal effort is always preferred in vacuum, whereas in forceps, maternal effort is absolutely not required. As far as prevention of cesarean section using a forceps, these are the definite indications like fetal distress. As I said earlier, it is futile to go for cesarean section as late as that, just because there is fetal distress, just because the fetal heart drips below 110. You don't have to worry. The moment the baby delivered, it will pick up like anything. If not, neonatists are always there to help us. If there's a cord prolapse late in the second stage, I'm not talking about first stage. If there is a cord prolapse in the first stage, most of the time it is due to CPD, which is missed. And that time cervix is also not dilated. It is better to take care of first cesarean section only. I am talking about cord prolapse, which occurs very late in the second stage. Suddenly the cord may just slip off when the membranes rupture at the end of second stage, which would be a surprise to you. But just because of that, if the cervix has fully dilated, if there is some space, to apply the forceps, you can quickly finish the delivery without taking her for cesarean section. So this is the cord prolapse where instrumental delivery can avoid a cesarean section. Preterm baby, of course, preterm baby, here again, the forceps is basically for the baby's sake rather than to avoid the cesarean section. In face presentation, of course, nowadays, if you diagnose face, whether it is mento anterior or mento posterior, nobody dares giving vaginal delivery. They will take up for cesarean section. Especially mento posterior, there is no mechanism of labor because we know that it will be sterno-brachmatic diameter that comes into play, which is almost 18 centimeters. There is no way you can deliver. In mento anterior, there is a possibility of anterior rotation and delivery. But as I said, usually these are the missed cases. But then if you diagnose that as late as second stage, instead of taking her for cesarean section, where it is going to be extremely difficult to flex the head and deliver, because at cesarean section, the biggest tip for better delivery is flex the head at any cost. Now here in face presentation, that the head is already extended and put your hand deep below the head and flex the head in the pelvic cavity and deliver is going to be Herculean task. You can simply complete the delivery using an outlet forceps or at the max low cavity forceps, and there it is easier to flex the baby's head and complete the delivery vaginally. So definitely in a missed phase presentation in second stage, late second stage, I would stress instrumental delivery is better than cesarean section. It is not just to avoid cesarean section, it is better to deliver vaginally. Cesarean section is going to be much more difficult than the vaginal delivery. The other one is after coming head of the breech. Here again, the baby is almost delivered, but it is stuck because the head is not budging, it is not flexing. Now, it is impossible to take this baby for cesarean section because almost 3/4, more than that, 90% of the baby is delivered. Can you push the baby inside and deliver by cesarean section? It is impossible. So this is a wonderful case where the instrumental skill is going to be extremely useful. You can use a Piper's forceps. If you don't have Piper's forceps, you can use simply a low cavity forceps. The mechanism is very simple. You can wrap the baby in a breech towel, lift it up so that the baby parts, the legs, limbs, and the cord will not come in the way. Apply the blades on either side of the baby head. It is mostly a cephalic application here. And then you try to flex the baby's head and deliver. These are the words, but what actually you do is you are trying to do the upward direction traction of the forceps. Of course, the assistant can give a suprapubic pressure. Now, I use the word apply the forceps, cephalic application, lock the blades, and then traction. These are the three important components of a forceps delivery. Application, there are two types, pelvic application and cephalic application. But if you don't consider the baby, both applications are wrong. But when you consider the baby, that is the fully flexed baby, both applications will coincide. What does it mean? Pelvic application means left blade on the left side of the pelvis, right blade is on the right side of the pelvis. But if the baby is not rotated, if it is the transverse direction, then the right blade is going to be applied on the face of the baby. Now, what is cephalic application? In cephalic application, left blade is on the left side of the baby, right blade is on the right side of the baby. Now, here again, if the baby is in transverse position, if you simply apply this manner, the mother's pelvis vessels will be torn. But when the baby is fully flexed and fully rotated, to your surprise,
Can I just interrupt?
baby's
The
left.
slides are not moving, I think.
Yeah, I'm not moving the slides. You've seen now the indicated maternal indication and fetal indication.
Yes, sir.
Yeah.
You can see.
Okay. I was not moving the slides. I was just explaining. So what happens is in a fully flexed and fully rotated head, whether you apply cephalic wise, whether you apply pelvic wise, they will coincide. The left side of the baby will be on the left side of the pelvis, right side of the baby will be on the right side of the pelvis because they're exactly opposite to each other. So you will have a successful vaginal delivery. Now, has the slide moved? Yeah? Somebody can answer?
Yeah.
Yeah. Okay. Now, we looked at the indication of forceps, but let us see which are those forceps deliveries that can reduce the cesarean section rate. As I explained earlier already, I am reiterating that the forceps applied in late second stage because of delay due to short rotation by 45 degree. Both are COG Green Top guidelines as well as in Williams, latest Williams, it is said that up to 45 degree short of rotation, you can use both outlet forceps as well as low cavity forceps. But traditional teaching has been head should be fully rotated if you want to apply the outlet forceps. Maternal exertion is one of the definite forceps deliveries that will avoid the cesarean section. Cord collapse in second stage and fetal distress in second stage. Please remember, late second stage cesarean delivery is equally difficult and disastrous. As I told, the cervical rim is so thinned out, the lower segment is so thinned out, baby is so deep, it is impossible, almost impossible, to get the baby from above without injuring the lower segment, extension of the lower segment incision, or injuring the bladder, vagina, lacerations. It is a mess, actually. The late cesarean section, if you have done once, you realize it is so difficult, as difficult or maybe more difficult than a late second stage instrumental delivery. But then again, you can't be blind. You can't be blindly using instrument. You can't be blindly doing cesarean section. You have to be very judicious. Best is to anticipate the problem early and take action early. Now I will move on to the vacuum delivery. Now, vacuum delivery has become very popular because it is very easy to use. Anybody can use, even the novice can use this. Only thing is you have to make sure that the vacuum cup is not gripping the cervical rim. Other than that, wherever you apply vacuum is okay. But we always say apply vacuum as much as possible posteriorly, near the occiput. You will not go wrong. There is something called vacuum distance and all that. That is for another day for undergraduate teaching. But here, what are the indications? I have written here almost same as forceps. That means wherever you are thinking of forceps, you can use vacuum. But we should be aware of the contraindications of vacuum delivery, which I'm going to talk shortly. Vacuum is especially good at auto rotation. As I already mentioned earlier, when you apply vacuum correctly and simply pull down, you don't have to worry about which direction I have to pull. You have to be always perpendicular to the cup. The direction of pull is always perpendicular cup. As the baby comes down, because of the pelvic configuration itself, if there is space, the baby will have what is called auto rotation. This is the biggest advantage of vacuum over forceps. Whereas in forceps, you have to use the Killian forceps. Unless you know the art of using it, it is very, very disastrous. It's going to be very difficult. The other thing is it can be applied even before full dilatation, theoretically, and relatively higher station, again theoretically. In the brackets I have written, full dilatation is always preferred and +3 station is always preferred. At the max, you can go up to +2 station as in case of forceps. But theoretically, let us say the cervix is not fully dilated, up to 8 centimeters is good enough. There are different types of cups that are available, and slightly higher station is also better. But for a successful vaginal delivery, you better wait for full dilatation of cervix and little lower +2 or +3 station, unless there is a very bad fetal distress. In maternal exhaustion, as I said earlier many times, forceps is better than the vacuum. What are the basic rules of vacuum delivery? Application to delivery time should not be more than 15 minutes, which means you get maximum 2 to 3 attempts. Once you apply the vacuum, if you have 3 contractions in 10 minutes, you get roughly 3 pulls only. The number 2, with every pull, the head, not just the scalp, because if you apply vacuum, sometimes in a caput, you feel that it is coming down, but it is caput which is coming down. We have to make sure that the head is coming down with each pull. And another rule is not more than 2 reapplications. In fact, with 1 application, with 3 pulls, it should come down. That is not more than 15 minutes. But sometimes it can slip. When the vacuum slips, you must suspect there is something wrong. There is no space for auto rotation, or maybe there is molding, or maybe there is caput. But still, you can apply 1 more time, but not more than 2 reapplications of the cup. If the cup slips twice, that means there is something seriously wrong. Maybe a big caput, maybe a big, the molding, or there is no space for auto rotation. You must give up and you must go for section. No forceps after vacuum failure. This is a very, 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 very important point. I'm telling at least 6 times, 7 times I've told very important, because what is called sequential instrumentation is not allowed. What do you mean by that? If vacuum fails, no forceps. If forceps fails, no vacuum. If either of them fails, straight away go for cesarean section. Vacuum delivery that can reduce the cesarean are judiciously performed vacuum delivery in cases of occipito-posterior, where rotation is the main issue. And as I told, vacuum is an expert for autorotation. This is the place where the vacuum shows its value. It is very, very handy in cases of occipito-posterior to avoid a cesarean section. However, one should rule out very high station. If there is a deep transverse arrest at the 0 station, better to avoid vacuum, better to go for cesarean delivery, because here the problem is not only of the power, the problem is of the pelvis. I always teach the students there is a problem of the power and problem of the pelvis. A deep transverse arrest at 0 station talks about problem of the pelvis, maybe mid cavity contraction. This case will never succeed with the vacuum. Better to go for section. Whereas in multigravida, if the rotation is not complete in occipito-posterior, it is because of the power. She has already delivered once. Pelvis is normal, but multis will have a lack of power, so the head is not rotating. In these cases, vacuum will be handy. Second one, as I said, large caput and molding is no for vacuum delivery. Lack of space for auto-rotation. Yes, the advantage of vacuum delivery is auto-rotation, but you need to have a space for auto-rotation. If the head is jammed, or if the lower portion is coning, outlet is contracted, vacuum is not going to help you. Narrowing of the pelvic outlet, vacuum is not going to help you. Now, I never spoke about contraindication for forceps, but I am talking about contraindications for vacuum. Cot prolapse with high head, better to go for section. Preterm baby, definitely no for vacuum, because you may get the brain out of the baby. Face presentation, don't damage the beautiful face. After coming head of the breech, again, you will have to apply the vacuum on the face here. Don't apply vacuum in cases of breech, Piper's forceps or low cavity forceps. Excessive caput and molding, I have already told you in the previous slide. Bleeding from the scalp, it may increase if you use vacuum. So if there is a bleeding for any reason, you should not use vacuum. Mother is totally exhausted. I'm telling it the 4th or 5th time that if mother is exhausted, forceps is a better instrument than vacuum. Absolute requirement for instrumental vaginal delivery. I am just trying to tell things in different ways, but I'm telling the same thing in different slides with different headings. What do you mean by absolute requirement for IVD? A skilled obstetrician and a neonatologist. Skilled obstetrician is a must. If you don't know how to use the instrument, better not use it. If you don't have a neonatologist in your setup, don't use instruments, because there can be sudden problems for the baby and you should have a neonatologist. Double setup. Now, I'm talking about 1369 formula of RCOG. What is that? At 1 minute, you diagnose the distress of the baby. In 3 minutes, you wait. If the distress remains, you transfer the mother to the OT, which may take around 6 minutes. At 6 minutes, you reassess. By 9 minutes, you should try an instrument inside the OT. Now, it could be vacuum or it could be forceps. But 12 minutes, if nothing happens, you must go ahead with cesarean section. So most of us now believe in applying late second stage instruments in a double setup. In a place like Manipal and other tertiary care hospitals, the OT is next door. So you can try it in the labor room itself, or you can shift the mother to the OT in the presence of neonatologist as well as anesthetist. You can apply the instrument. If you fail, don't worry, go ahead for cesarean section. But you should not have a bent of mind hell-bent for vaginal delivery. So this is called trial forceps and failed forceps. Trial forceps is you are just trying a last-ditch attempt, whereas failed forceps is you are determined to deliver by forceps and you will deliver, but the baby is moribund baby. That is a failed forceps, even though you have achieved vaginal delivery. Please remember this. Instruments. Of course, you must have right instruments, autoclaved, ready to use. Low cavity outlet forceps or both silastic and metallic cups. And in metallic cups, there are anterior cups and posterior cups. Posterior cup is for occipito-posterior, which will not damage the rectum. Anterior cup is for a straightforward delivery. Proper counseling. This is extremely important. Probably you can do this counseling beforehand whenever you anticipate instrumental delivery. Maybe a case of occipito-posterior, maybe a case of previous cesarean section left for vaginal delivery, or maybe a case of preterm delivery. You must explain that you might be using instruments. And you must also explain, in case you are not successful, you may take up for emergency cesarean section. A proper counseling will definitely save you as well as the mother and the baby. And the most important one is informed consent, not only for IVD, that is instrumental vaginal delivery, but also for an emergency cesarean delivery. Mother is already in distress. You can't be taking signature from her at that time. A proper pre-counseling and pre-consent is very, very important. Now I come to absolute contraindications for the IVDs. A non-skilled obstetrician, all the contraindications which I mentioned for vacuum, that is preterm delivery, phase presentation, breech presentation, big caput, and big molding, and maternal exhaustion. Failed forceps. I have already explained what is failed forceps. That is a determined person who knows that he might fail and still wants to deliver vaginally. Sequential instrumental usage. I have increased the font size purposely because no forceps after the failure of vacuum, no vacuum after the failure of the forceps. If either of them fail, better to take up for cesarean section only. What are the complications? Of course, there are a whole lot of complications for vacuum, lacerations of the mother's vagina, cervix, or vulva. It can lead to traumatic PPH, cephalhematoma, subaponeurotic hemorrhage in the fetus, intracranial hemorrhage. This is one of the worst things, but it will recover within no time. Retinal hemorrhage. We had one case in Manipal, but luckily after 3 months, the baby gained back the vision. Forceps, of course, same set of lacerations to vagina, cervix, and vulva. Cephalhematoma also can occur. Intracranial hemorrhage also can occur. But additional problems with forceps are fracture skull, facial nerve injuries, and ocular trauma. These could be sometimes permanent. Now I'll just pitch vacuum versus forceps. According to Cochrane review, vacuum extractor associated with significantly less maternal trauma, more vaginal deliveries, fewer sections with vacuum extractor compared to forceps. Vacuum extraction is associated with lower usage of the RA, that is regional anesthesia or general anesthesia, but with apparently less pain at delivery and significantly less pain at 24 hours. Vacuum extractor was associated with an increase in neonatal cephalhematoma and retinal hemorrhage, of course, but I said neither of these problems have been linked to long-term complications. Usually they resolve within 3 months. No significant differences in numbers of babies requiring phototherapy. Now, finally, what is the evidence with regards to reduction in cesarean section rate with the increased instrumental delivery? Yes, high-quality evidence on cesarean rate reduction directly from increasing instrumental delivery is limited. I looked into all the literature, as I said. I found few Cochrane reviews. 2021 Cochrane review said that instruments for assisted vaginal birth reported on success and safety of forceps versus vacuum, but did not directly quantify C-section reduction per se. Rather, it focused on outcomes of the assisted births. As I said, nobody has pitched instrumental delivery versus decrease in the cesarean rate, but they have always been praising better to use instrumental delivery, it is safe, and things like that. Even 2022 Cochrane review, it said comparing trials of instrumental delivery versus immediate cesarean for anticipated difficult births found no randomized trials. It suggested that for anticipated difficult assisted vaginal births, it may be preferable to go straight to cesarean section. That's what I said. Sometimes you have to be very judicious. You have to be open. You should not say, I will do section easily, or you should not be saying that at any cost, I will deliver vaginally. You should be very prudent. You should be very considered in your decisions and take appropriate decision at appropriate time. The advantage of doing an immediate cesarean section would be a reduced risk for morbidity for both mother and baby from a failed attempt instrumental birth. You just saw the complications of instrumental delivery. However, the disadvantages of routinely doing a cesarean section in these circumstances are an increased risk of morbidity from cesarean section, which often manifests itself as a subsequent birth. That's why it is always better to be prudent in first stage itself. But always we will have surprises in second stage, even a well-monitored case. And of course, the all emergency cases which come straight away from outside are definitely big challenges, both for instrumental delivery as well as for late cesarean section. Cochrane Review 2000, the old one, showed that vacuum delivery was associated with fewer C-sections, which I've already told. Comparison of vacuum or forceps use was likely because of vacuum attempts may lead to successful vaginal delivery without needing a C-section. Successful instrumental vaginal deliveries avert the need for cesarean section in women with prolonged second stage failure progress. This is a local, our Indian study. Dr. Gupta and Bhagat, they published it in International Journal of Clinical Obstetrics. This was 2023. When vacuum or forceps was appropriately used, successful vaginal births are achieved without surgery, which by definition contributes to fewer sections. Another paper which said that WHO and major obstetrics organizations consider operative vaginal delivery an important component of basic emergency obstetric care, in part because it can avert cesarean sections when vaginal delivery would otherwise be impossible without intervention. These are all opinions rather than randomized control studies. So how can we do that? Yes, we can do randomized control studies. The cases which are for instrumental delivery, we can do them into two groups. One is for cesarean section, other one is for instrumental delivery. And then we can find whether it can really help us. But it's easier to say rather than to get ethical clearance for such studies. That's why probably many of them are avoiding randomized controlled prospective studies. Most of them are retrospective analysis. What are the limitations of all these evidences? There is no large RCT directly comparing strategy of attempting instrumental delivery versus defaulting to a section in second stage of labor. Much of the evidence comes from observational studies, institutional trend analysis, which can show correlations but do not prove causation. Finally, let me now answer what is the better answer for the question whether instrumental delivery can reduce the cesarean section. Having understood all the pros and cons of instrumental delivery, cesarean section, when to do it, how to do it, what to avoid, what to encourage, my final answer is I don't want to give a quick answer like yes or no. I don't want to give a smart answer. I don't want to give a, other answers. The better answer is judicious use, meaning you know the indications, you know which instrument to use and all that. Appropriate instrument, use of appropriate instrument in well-selected patient. You should know which patient requires what. In the hands of skilled obstetrician, in late second stage, in a double setup, may avert avoidable cesarean section with a good outcome. Without a good outcome, there is no point at all. So I think this slide is almost like a disclaimer slide. I put all possible disclaimers, judicious use of appropriate instrument in well-selected patient in the hands of skilled obstetrician in late second stage in a double setup may avert avoidable cesarean section with a good outcome. What are the carry-home? No rotational forceps, no vacuum for preterm phase and breech, no sequential instrument. Don't be biased either for vaginal delivery or for cesarean section. Use instrumental vaginal delivery in double setup. Have the presence of neonatologist. Thank you very much for the opportunity.
Thank you.
Thank you so much, Muralidhar sir, for a wonderful and enriching talk. I would request Dr. Hafizur to kindly comment on
Thank
the
you.
talk.
Thank you, Satabdi. Thank you, Paiser, so much. It was always wonderful to listen to you, and I have been a great fan of you, as I know you are a great academician, sir. I have been seeing you from so many years as not only academician, as a leader also. I have seen you very closely, and your academic, the excellence you have also there. I think we have, sir, given the everything, whatever is required. And with the worst as well as the with the evidence and the later part, and the most important is that actually the take-home message, that is where it need to be. I think, sir, you have rightly said that it is the assessment, correct assessment is important. So that is right, guys, and select the right instruments, sir, you also told. And sometime, as I would like to say, sometime because that is I have seen, don't hesitate to abandon the if there, not to keep any time that you need to deliver, because being a teaching institution, sometime I have seen when I was a postgraduate students, some teachers actually they thought like delivering like that. So in those situations, what I feel at what time need to abandon, and if required to go for doing a time decision, I think that gives the best. It's a better outcome. And sir, I really appreciate that you have given the very good and very excellent presentation on that. And I think it's really going to helpful for all of us. And thank you so much, Dr. Kalyan Barma, sir. I know you as being that is in the many, many years. And you have very good, again, academic things as well as leadership potential. I wish you all the best. And my sincere regards to Pragya ma'am, Sita ma'am, and Suman ma'am as well. So thank you so much, Paiser, and to issues.
Thank you, officer.
Yeah.
Thank you, officer, for your comments. And thank you, everyone, for appreciating online, putting your messages. Thank you.
Over to you, Satabdi.
Yes, Deepanita ma'am, are you there? Yeah.
Deepanita, you there? Deepanita is there.
Deepanita ma'am is there. Even I
Yeah,
saw.
she's there.
Yeah, yeah.
Hello, sorry I got late. I was actually doing an instrumental delivery in OT, a trial of instrumental delivery while this had started. My junior had started off doing it, and then I had to be involved because I didn't want to fall into trouble later on. It was a second stage poor maternal efforts, and it went well, thankfully, but missed most of the talk. But then I got the last two slides, Kalyan sir, and it was so apt, the last slide that you put up, in good hands and with appropriate patient choice and appropriate instrument choice. It can be so gratifying to do a good delivery, but then outcome is the main thing, and we should not shy away from abandoning it or not doing it and always doing it in a double setup. All that is, these are such golden words, sir. I'm really sorry I missed the rest of it, but these are such guiding lights for us.
Thank you, Dr. Deepanvita, and congratulations on successful instrumental delivery.
Trained in the era where there were such great teachers with instrumental deliveries. This talk of yours will go a long way to reinforce the knowledge and art that we have already got, and hope we can pass part of it to our juniors as well, sir. Thank you very much, Kalyan sir, and thanks everybody. I'm really sorry I missed the first part of it.
Thank you, Dr. Muralidhar sir, for such an elaborate talk. And it is a time of the need that we should, again, the resurgence of the operative vaginal delivery. That is what is main crux of this talk. Important for us that he has covered almost everything for the panel. We are going to reduce the time to 40 minutes for the panel than 1 hour, because almost all slides he has covered. And really, he's a teacher of teachers, and it's such a nice to listen to such talks. And these are the legacy we should continue in India, so that we are again torchbearer in operative vaginal delivery in next decade. Thank you so much, sir, for this.
Thank you, Dr. Kalyan.
Thank you, sir.
I wish you all the best for your
Thank you,
election.
Thank you.
Thank you, Kalyan sir. Thank you once again, Murlidhar sir. And indeed, a great coincidence that Dipanita ma'am was actually conducting an instrumental delivery. So all the more need of the hour for such talks, so we can take right decisions. And yes, very rightly said, abandon if necessary at the right time. So thank you once again, everyone. Thank you, chairpersons. Thank you, Murlidhar sir. We will move on to the panel discussion. As Kalyan sir said, much of it I think Murlidhar sir has already covered in his talk, but we will try to discuss some more points. The panel discussion is on case-based scenarios which are related to the complications of instrumental deliveries. Our moderator for the day is Dr. Kalyan Barmade sir, and we have a very good dynamic group of panelists from across 5 societies of Eastern India. Can I have the slides? Our first panelist is Dr. Nivedita Mishra. Dr. Nivedita Mishra is a obstetric and gynecologist and a laparoscopic surgeon, a very dear friend of mine from Ranchi. Welcome, Dr. Nivedita. Our next panelist is Dr. Sutapa Seeth ma'am. Ma'am is has done her MBBS from Medical College and MS from RG College, Kolkata. She has also done her observership in maternal medicine from Singapore and is a senior consultant at Health World Hospitals, Durgapur. Welcome, ma'am. Our next panelist is, next slide, please, Prerak, is Dr. Shayoni Dolui, ma'am. Dr. Shayoni is has done her MS from Calcutta Medical College. She is one of the senior consultants at Durgapur. She has various publications to her credit and also has interest in high-risk pregnancy and laparoscopy. Welcome, Shayani ma'am. Prerak, next slide, please.
Dr. Reena Barnwal.
Yes, Dr. Reena Barnwal, ma'am. Dr. Reena ma'am is a senior consultant at SSMC Hospital at Dhanbad. She is also a visiting consultant at Asian Jalan Hospital, and her areas of interest are high-risk obstetrics, infertility, and laparoscopy. Welcome, Reena ma'am. Our next panelist is Dr. Deepali Prasad, again a dear friend of mine. Ma'am is a professor in the Department of Ops and Gynecology at IGIMS, Patna. She also has a teaching experiences over 16 years, and her special interest fields are high-risk pregnancy and fetal medicine. Welcome, Dr. Deepali, ma'am. Our next panelist is Dr. Simi Kumari. Dr. Simi is a senior consultant and infertility specialist practicing at Hope IVF in Patna. She is the co-founder and managing director of the same. She is also an executive member of the IFS Bihar chapter and has been faculty in various state and national conferences. Welcome, Dr. Simi. Prerak, next one, please. Our next panelist is Dr. Sadhna Kumari ma'am. Dr. Sadhna Kumari ma'am is director at Sadhna Hospital at Dhanbad. She is the former secretary of the Dhanbad Obs-Gynae Society, and she has participated in various Yuva Foxies and Foxy conferences. Welcome, Sadhna ma'am. Next, Prerak. Our next panelist is Dr. Namita Srivastav. Dr. Namita is a high-risk maternal and fetal medicine specialist and assistant professor at NSMCH at Beta Patna. She is also the director of the Nandan Maternity and Fetal Medicine Center of Patna. Welcome, Dr. Namita. Our next panelist is Dr. Santwana Sharan ma'am. Dr. Santwana Sharan ma'am is a consultant gynecologist trained in emergency obstetrics at Mother and Child Health Care Center in the Ramgarh cantonment. She also has been the vice president of the East Zone Doctors Wing in 2022 and the convener for the National IMA. Welcome, Santwana ma'am. Ma'am is one of the very enthusiastic persons and always ready to do whatever that we ask her to do. Welcome, ma'am. Our next panelist is Dr. Shruti Prabha, again a dear friend of mine. Ma'am is the managing director and consultant gynecologist at Srishti Hospital at Ranchi and also a specialist at Sadar Hospital of Ranchi. She has various accolades to her credit, including the Rangila Sinha Young Gynecologist Award in 2013. Welcome, Dr. Shruti. Over to you, Kalyan sir. Looking forward to an excellent panel.
Welcome, everyone. I'm going to start the panel on some of the cases. Already introduction has been done. And now our basic focus will be just to discuss certain cases which are there pertinent to your practice. Operative vaginal delivery, in which the operator uses devices to assist mother in transiting fetus to extrauterine life. It generates forces that augment maternal pushing to deliver the fetus vaginally. The traction is the most important functions of these devices. The interesting stories is Peter Chamberlain in 1601, who first used forceps for the first time. And it was considered as a gift from God, which was kept secret in the Chamberlain families for the years. Thomas Denman stated that the head of the child shall have rested for 6 hours as low as the perineum before the forceps are applied. Through the pain should have ceased during that time, and this was called Denman's law, then became widely accepted as standard for the forceps deliveries. The biggest obstacle which came and tragedy was there of Princess Charlotte's death, which Charlotte was a princess who died in the labor. She was stuck in the labor for 6 to 8 hours. Her labor total process was for 40 hours. And that's how she delivered a dead fetus. And then she died after delivery because of the complications. Some say because of the PPH. Some say it was of the pulmonary embolism. And Sir Richard Croft, who delivered her, died of suicide because of the humiliation he got, because that was the last person of that dynasty, that was Wales Kingdom. The incidence of instrumental delivery is around 2.5 to 5%. It is significantly lower than the UK, where it is around 10 to 12%. Typical range, many Indian studies show 2.5 to 5%. But as we know, we Indians lack the studies. We don't report many of these, and that is what is very important. High rates in tertiary centers, as Sir was actually talking, the highest rate of instrumental delivery is in the tertiary care centers, where there are 1+ doctors are doing the delivery procedures, maybe a big center, PG Med Teaching Institute, or a medical college. The low rates are there due to lack of training and equipment issues. We are emphasizing here that because of the inadequate training, the next generation is hardly going to use forceps and vacuum, and that is going to be there as less as 1% in next 10 years. And as you can see, the comparison of operative deliveries in the USA, already it is cesarean section rate is between 30 to 35%, and it is falling towards 1% to 2% as instrumental delivery. So we are going to start the first case. A 26-year-old primary gravida with term gestation was referred from the PSC by medical officer in view of prolonged second stage and mild meconium stain amniotic fluid. The second stage of labor for 1.5 to 2 hours. She had effective contraction with adequate pelvis, cervix fully dilated, fetal head at +2 station, position was occipito anterior. On admission, her CTG was reassuring. Mother appeared dehydrated and exhausted with pulse rate of 106, BP of 100/64, dry mouth. What should be the management protocol? We come to Dr. Reena Madam first. Can you unmute, Madam? Yes, Dr.
Good
Reena
evening,
Verma.
sir.
Good
Thank you
evening.
for the opportunity, and it was a very lovely session, and we devised everything. Thanks to sir. Bye, sir. So here I would like to say that first we have to resuscitate the patient, we have to assess her properly, and we have to confirm the findings, like she is actually occipito anterior, and confirm the station of the head. Since she is dehydrated, first we have to start with her fluids. In the meanwhile, we send her lab investigations, and we have to arrange her blood. Also, suppose she needs a cesarean section in spite of trying for instrumental delivery, we have to then we plan for instrumental delivery. We can choose both forceps and ventouse, but in this case, since the conditions are ideal, the patient she has plasticization, this is occipital anterior, and she's having good contractions. Patient is having good contractions, and fetal heart is assuring, so we can go for ventouse delivery, sir.
Okay, thank you so much, ma'am. So correction of maternal dehydration, get her routine lab because she's referred from the primary health center, assess her HB, cross-match blood, and keep it ready. So, Dr. Nivedita, madam, in your setup, you do cross-matching of blood for all delivery patients? Dr. Nivedita Mishra is there? Okay, Dr. Santwana. Can you unmute, madam? You need to unmute, madam. Santwana Sharan, madam.
Thank you, sir. Thank you so much for giving this opportunity to participate in such an enlightening topic, which is almost getting obsolete these days. We don't plan for instrumental deliveries very frequently, though I use forceps quite often, and I always give a try to a forceps whenever I feel like. So in this case, what I find that blood should be arranged for any patient who's exhausted, who's referred, and whose hemoglobin is doubtful. So we should, as madam said, we should recheck all the parameters, all the blood samples. And in our hospital, when the patient is registered and a routinely good antenatal checkup, we don't arrange for blood. But for a referred patient and in which we anticipate that instrumental delivery might fail, or there are chances of PPH as the patient is exhausted, dehydrated, and very tired, so we arrange blood in such cases.
Okay, so cross-matching is compulsory for today's world because of the medical legal
Yeah,
litigations.
cross-matching we always do, sir. Whenever there is
Yes.
a requirement of blood, we always do cross-match.
Yes, madam. So, Dr. Santavana, which instrument preferred? Already it has been answered by Dr. Rina ma'am, vacuum assisted delivery, also called as ventouse delivery. Now, Dr. Santavana, what are the components of the vacuum? Can you just elaborate for everyone's knowledge?
Yeah, ventouse is used commonly because there is a perception that ventouse is easier and gives better result, and it's less traumatic to mother and child. But we must have all the setup ready. Like, well, there should be a ventouse first of all, ventouse under a soft one or a metallic one or whatever is there available. It should be properly sterilized and kept. Then there should be one device to give a traction properly. Something to give traction properly. The instrument should be properly checked before using, because even if it is not in use for many times, sometimes when you just put the pressure, the suction pipe comes out, or there is some failure of the device being applied not properly. So the chain and device should be properly kept. The suction tube should be checked beforehand that it's working properly or not. The pressure gauges should be properly checked and kept in place. And everything should be just kept in place, like as madam said, we should reaffirm that the position is proper, the patient is hydrated, the cervix is dilated, and even if the head is high at a higher place, higher station, we must assess beforehand that how much pressure we can apply. And the position of the head should be reassessed, that however higher we can go at the occiput, that would be best for the patient, for the baby actually.
Thank you, ma'am. It was really nice. Dr. Sadhna, ma'am, how does this vacuum act, and what are the principles of action of the vacuum, ma'am?
Good evening to all, and thank you, Kalyan sir, for providing this wonderful platform. As the instrumental delivery is decreasing and it become obsolete in few years, and it is this type of educational platform is very useful for our newer generations. And vacuum acts by creating vacuum, and the most important thing in vacuum delivery is rotation. It also rotates the head and at the same time with maternal pushing effects. When doctor creates vacuum and pull the head down, delivery is anticipated.
Yes, so very important is the Chignon formation and traction, and also the flexion, if required, can be done with the, and there are soft cups and metallic cups which has advantages for this. So Dr. Namita, what are the preparation of the mother for the vacuum?
Sir, good evening, sir, and
Good
thank you for
evening.
providing this platform. Sir, most important thing for the preparation of mother is the first, for before anticipating any of the instrumental delivery, we must have consent from the attendants, and informed consent is very necessary. After that informed consent and explanation to the attendants and proper documentation, then sir, we should assess the patient that appropriate analgesia should be given, for maternal bladder should be emptied. There should be full ruptured of membranes. If there should be complete asepsis technique should be there. And sir, further more thing is that there is need of operator who is having skilled operator for performing the vacuum delivery. At least they should be at least the vacuum delivery should be done in presence of an skilled obstetrician. Even if it is conducted by any resident also, then there must be presence of that skilled resident, and presence of neonatologist should be also there, and it must be done in with a backup of cesarean section. If it gets failed, must be a backup for the cesarean section. And we should also assess for the anticipation of complications, such as there can be chances of shoulder dystocia, perineal tear, trauma. So we should have resuscitation instrument and pediatrician standby there so that they can help out in that condition.
Very rightly said by Dr. Namita madam that prerequisites for mother as well as preparation of the staff, operation theatre, light, and a backup of operation theatre, and pediatrician should be standby for such cases, and consent has to be taken for such procedure. Dr. Deepali madam, what are the prerequisites for vacuum, ma'am?
First of all, good evening to everyone, and
Good
thank you
evening,
for
ma'am.
being a part of this panel discussion. So, the prerequisites of vacuum and as for the forceps is more or less this same.
Same, yeah.
And the prerequisite is you have to take the proper examination of the patient, per abdominal examination, and that is the head is less than 1/5 palpable per abdomen. In the PV examination, the cervix is fully dilated, membrane ruptured. For the vacuum, it may be 8 centimeter dilatation or less dilatation. It is comfortable, but for the forceps, should be fully dilated, membrane is ruptured, and station of the head is a +2 station or in the perineum. And we should also look for the caput or the molding. If it is molding is +2, then you think of CPD, that is cephalopelvic disproportion, and also look for whether the pelvis is adequate or not. So these things must be kept in mind before taking the patient for the vacuum delivery.
So she has rightly told about all the prerequisites about the vacuum. Dr. Sutapa said, when we need to stop, you are attempting 1, 2 times. Is there any number where you are going to stop, Dr. Sutapa? Dr. Sutapa is there?
Everyone.
Yes, ma'am.
Yes, good evening, everyone. And thank you, Kalyan sir, for giving me the opportunity to be a part of this discussion. And for vacuum, and after application and after the negative suction is the suction is applied, when there are two pop-offs, when it is detached, then we must stop and then recheck whether we should re-examine. And if there is no descent after 3 set of pulls, and then also we should assess whether the assessment is correct or not, the presentation is correct or not, and whether the pelvis is adequate or not. And a maximum total of 15 to 30 minutes should be wait and not beyond that.
Yes, very rightly said. Whether oxytocin is on, secondly limited to 2 to 3 cup. What are the causes of pop-off or sleep-off, Dr. Sutapa?
If there is any tissue intervening inside, or if it is the suction is not applied properly, then it can happen. And or
Sometimes
incorrect
large capital also can
large
cause.
capital formation, yes.
Or
And
or any
inadequate pressure.
inadequate pressure or faulty equipment can cause the causes of pop-off or sleep-off. So, Dr. Dipali ma'am, what is failed vacuum?
With each of the failed vacuum is with each pull, there must be a descent of the head. If the fetus is not delivered within 3 pull, maximum of limited pull is a set of 3 pull. If it is not delivered, that is between 15 to 30 minutes, then it is called a failed vacuum. It means the cup is not properly applied, or there's a faulty technique of cup application on the fetal head.
Rightly said. Dr. Shruti Prabha, I can see. What are the complications of vacuum delivery for mother as well as fetus? You need to unmute, madam. Yes, please.
Good evening, sir.
Good
And
evening.
thank you, everyone. Good evening, everyone. Complication of vacuum delivery can be of maternal and that of fetal. Maternal delivery, there can be lacerations of genital tract, including vulva, cervix, perineum, and even anal sphincter complex can be damaged. But it is rare in case of vacuum, more in cases of forceps. But fetal, in case of fetal complications, the scalp damage is more in case of vacuum. There can be laceration of scalp, cephalomatoma, subanerotic hemorrhages, retinal damages, and face. Of course, if it is wrongly applied, there can be facial skin damage. But it is in case of forceps, there may be if applied at wrong places, it may damage the chick's facial skin. But in forceps, there may be facial nerve palsy. But these are in cases of vacuum.
Yes, maternal complications are slightly rare in vacuum, but more in forceps. And fetal complication is important in cephal hematoma, which requires observation, usually covers in 2 to 3 weeks. And laceration we can do a suturing if required. And these are the few complications if it is really problematic. So, Dr. Reena Barnwal, ma'am, what are the contraindications of forceps as well as vacuum to prevent such complications?
The most important contraindication is that presentation should be right. Fetal presentation should be cephalic, and occiput should be the presenting part, and there should not be any cephalopelvic disproportion. There should the baby should be of at least 1.5 kg. It should not be a preterm baby, and no face presentation or and the patient, there should not be any history of bone mineralization problems in the which can be happened in the fetus, like osteogenesis imperfecta, or there can be bleeding disorder in the baby. In those conditions, we should not apply any ventures or forceps.
And there are certain maternal indication like thrombocytopenia.
The HIV positive patients also we should avoid, sir.
And important is you need to assess what is the baby weight. That is very important. So many times a macrosomic baby in Indian scenario more than 4 kg can be a difficulty to deliver these babies. Thank you so much, madam. Dr. Namita, can you tell me about the management of the cervical lacerations in case of vacuum as well as forceps deliveries?
Thank you, sir, for the opportunity. Sir, cervical tear repair, basically we have, when there is a bleeding from after the delivery, we have to do complete cervicovaginal exploration, uterocervicovaginal exploration. And then we have to assess where is the tear, from where it is bleeding. It can be from cervix, it can be from vagina, or it can be from any paraurethral tear also which can bleed. Particularly in case of cervical tear, we use 3 sponge holding forceps, and through that we use to assess where, in which side the tear is present. Usually the tear is usually on the right lateral or on the left lateral side, most commonly present. We have to reach to the extent, till the extent where the tear is present, and we have to catch hold the apex of the tear, and the first bite should be taken above that apex, and then we can take sir, usually we take interrupted sutures with the catgut, and it works.
Very nicely said, because we are losing this art of vaginal suturing. 3 sponge roll technique is very important. First, apply at 12 o'clock, 9 o'clock, 6 o'clock. See whether there are any laceration, then go clockwise and see about the laceration, and you can suture this. Now, this is Dr. Sayoni Dolia has joined. Madam, this is for you. 27-year-old multigravid at 40 weeks, 4 days is fully dilated, fully effaced, and meconium stain liquor. CTG is showing persistent lead deceleration below 100. Head is at 3+ station, occipito anterior position. What is the best mode of delivery, and whether you are going to use forceps or vacuum, and why?
Good evening, everyone. Thank you for giving me the opportunity. As Dr. Pai sir said already, that
Yes.
as there is fetal distress, so I prefer forceps here. And as it is multigravida, so there is lax perineal muscle also. So in that case, I prefer forceps than vacuum.
Dr. Sayoni, why not cesarean section for this case?
Cesarean sections actually already. Can I see the question? Can I see the question?
Yes, ma'am. This was
The case, yeah. Actually, it is a multigravida, and
right.
it is already station is at +3.
+3.
And cesarean section will take time. One thing we can do, we can try forceps at our operation theater or near the operation theater, so that if it failed, we can immediately shift to the cesarean section. Or in
Okay.
case of as Sir already told, in case of that deeply engaged head, it is difficult for cesarean section. It will extend in lower segment or injured bladder like thing.
Very
Excuse me,
rightly said.
sir,
And
I
broad
would like
ligament
to
hemorrhage.
add
Dr.
one
Rina,
thing here,
ma'am,
sir.
please. Yes.
So actually, it depends upon the expertise of the
Expert.
obstetrician also. If the obstetrician is expertised in ventouse, why not go for ventouse in this case? Because it will take, I think, 4 or 5 minutes to create the pressure, and it has lesser chance of injury, and might as well go for that also.
Very rightly said. Usually forceps will take less than 1 minute. That's why it is indicated. But if he's not well versed with applying the forceps, we can try for the vacuum. And always better to do it in the operation theater or
Sir,
near
and we
operation.
have faced here that the attendants, they do not give consent for forceps, rather they give consent for ventouse. Thanks to Sir Three Idiots movie, ventouse has gained lot of pop and show, and people agree, sir. That is what I have felt here.
Right. Dr. Namita, ma'am, what are the prerequisites of forceps? Already has been told there is a mnemonics of A, B, C, D, E, F, G, H, I, H that we have learned. What are the indications for forceps delivery, madam?
Sir, indications for forceps delivery. Sir, most important, for forceps, we have to see if there is maternal exhaustion is there, any cardiac disease to the mother, if there is severe anemia and their mother is having severe exhaustion. In that particular case, if there is delayed second stage of the labor, if the mother is multiparous or even nulliparous, and if the second stage of labor is extended due to the regional anesthesia, that can be the cause. And sir, hypertension, if there is any spine disorder in which the lower maternal effort is missing, in that particular condition, if there is fetal compromise, For example, if there is any suspected fetal compromise, thick meconium, and if there is babies at +2 station or at perineum, and there is sufficient space, multigravida, so we can easily apply forceps. Non-assuring fetal heart rate is there. Sir, we can also apply in certain conditions, for example, deflexed head in case of mento anterior face presentation. It can be applied in the during the after delivery of the breech. And sir, in those conditions also we can apply these conditions in occipital posterior also, sir. But most better is vacuum for occipital posterior.
Okay, how many of you are using forceps routinely in your clinical practice? I think Dr. Shruti, you are using, or somebody told me that you are using.
Yes, sir.
Dr. Dipali, I suppose. Dr. Santwana.
Yes.
Yeah,
Yes,
I
we are
use
using.
that.
Yes, sir.
So
Yes, sir.
which one is better? I mean,
I also use,
yeah,
sir.
Dr. Sadhna ma'am. Can you just guide us
Sometimes.
low forceps, mid forceps, high forceps, and what are the advantages and disadvantages, and what is the practice you are doing in a modern obstetrics, ma'am?
Sir, in modern obstetric, we are strictly and only using outlet forceps.
That's right.
Because
Very
as Reena
Yes,
told,
yes.
sir,
So what are
as
the
Reena
Even I
told,
use
because
only
the docs
outlet forceps,
give
sir, when it is
give
very
the
safe and less chances of trauma to mother and
outlet
baby.
forceps,
Only
and
outlets, sir.
when we explain the risk factors, what are the risks to the baby, public usually don't give the consent, and we
We
usually
don't give
use
the
outlet forceps in cases of emergency, just like when there is severe bradycardia, fetal bradycardia, or mother is not pushing or curtail the second stage of the labor. We are
And to
These
the
are the
patient who are referred from
conditions,
different hospitals, sir, they come to us in the last moment with
last
head
moment.
just peeping through the introitus, and you just have to put a forceps and pull it out.
Sir, this is the very
So
good
nobody
platform.
is
Sir,
using mid
I
forceps.
I just want to ask you one question, sir, because sometimes we have to land in such situation, there is severe bradycardia, and the patient public is not giving the consent for forceps. So we sometimes use forceps even without consent, and it is not mentioned in the case sheet that we have used forceps. So is it right, sir, or not?
No, we have to take a consent, because if there is a fracture of skull bone, if there is any rupture, if it is trauma, extension, then how are you going to explain, Dr. Sadhna madam?
Injury.
So it's always better
Sir,
to take a consent for
sir,
any of the mid cavity low forceps. Outlet forceps is fine, because it is not going to have any problem. But without
no, no.
consent, please don't apply any of the forceps. You need to take a consent. Even Dr. Pai sir was talking about taking a cesarean section consent prior hand if it is going to fail, because she's in a agony, she may be in a saddle anesthesia or something, she might be not in a proper position to give a consent later on. So it's always better to take a be safe medico-legally before doing any of these operative vaginal deliveries. And when we talk about the mid forceps, my teacher, Dr. M.J. Jassawala from Wadia Hospital, used to use mid forceps for all their patients. So it is about the expertise of the person who is doing it. Otherwise, if you're not very comfortable, outlet forceps when scalp is visible, fetal skull has reached the pelvic floor, sagittal suture is in the epidiameter, and fetal is at or on the perineum, and rotation doesn't exceed 45 degrees. These are the indications of outlet forceps where you can safely apply the forceps in the modern obstetrics, because even a single patient who has some injury to the fetus are not going to help you in, is going to sue you in the court of law, and nobody is going to help you if you are not taken any of the consents. So when you talk about the forceps, there are a blade, shank, and lock, and the handles. It can have, there are two curves. One is called as a cephalic curve, one is called as the pelvic curve. And these are the classic forceps: primary traction. The lock can be English lock, parallel like Simpson, Dilly's, we use routinely as a Dilly's forceps, and even overlapping Maclean forceps were available. So there are, I was talking about the mid forceps, that is Gillan forceps, where they were rotational forceps which were used previously by the expert hands, and they are not to be used in a modern obstetrics until you are expert in using all these forceps. And somebody was talking about the Piper's forceps for after coming head of the bridge, that is allowed for use all these in the cases of bridge delivery. But after the trial of the term bridge trial, we suggested that all primi or multigravida, all breaches for full term has to be delivered by a cesarean section, that is term bridge trial, which has been phase 1 and phase 2 has come out. So it is always better to be safe than sorry for these patients. And the forceps indication is important for forceps application. Check the position, whether it's occipital anterior or occipital posterior. Check the station, whether it is +2 or below, and low and outlet forceps are acceptable because it has minimal trauma even if it causes trauma. The assembly, can somebody talk about the assembly who is using the forceps? Dr. Sadhna, madam, you are using the forceps?
Yes,
please.
yes. If we apply the forceps blades, first of all, to assemble the blades so that the side of it should be introduced first and properly applied either pelvic application. Sometimes if blade is not locked, immediately lock. Hello,
Yes, madam. Yes.
am I audible?
Yes, you are audible, ma'am.
What are the landmarks for the proper application of the forceps? We have to chair and first of all, left blade is right hand is introduced into the pelvic cavity to protect the pelvic wall and guide the forceps blade. Forceps blade is gradually introduced with sliding forces using the right thumb and to protect the pelvic side wall and guide the blade, and when we properly push it into the cavity, it will glow properly and sit on the perineum without any assistant. Then we gradually apply right blade in the same technique and slightly push down on the perineum. Then both the blades are locked properly, and then we gradually give traction on the blades gradually, initially horizontally, then upward towards the mother's abdomen, and gradually baby is delivered, and we ask the assistant to support the perineum to prevent perineal tear or rectal tear.
And then first right blade is removed and then the left
Right
blade
blade is removed, and yes, first right blade is removed and then the left blade is removed, and baby is referred to the pediatrician, which are already present in our labor room, to resuscitate.
Sir, I have a question, sir. I have a question for you, sir. Why
Yes,
do we use right blade first, sir? Suppose we use left blade, because I have seen few doctors, even I feel comfortable using left blade first.
First is always left blade, then only right blade.
Yeah. That is what I
And that's
use
what
left blade.
I was talking about the disarticulation, madam.
Disarticulation.
But the
Okay.
locking system is such that first we have to
Introduction
is with
is
right
first
blade.
left blade, and with the disarticulation, it is right blade that is sit on the left blade. That's
Because
why
it
the
is
right
over,
blade
huh? It's okay.
is to be taken out first.
Okay, sir.
Yes, Dr. Reena ma'am, what are the complications of forceps? Specifically, you can see the picture.
So this picture, it is showing that the baby is having left side facial palsy, sir.
Very
And it is
rightly said.
and
So,
in this patient, there can be babies can have nerve injuries, brachial plexus injuries, corneal abrasion. There can be a cranial fracture, intracranial hemorrhage, cephalohematoma, and cerebral palsy also. And in mother, there can be vaginal tears, cervical tears, PPH can be there, sir.
very rightly said.
And if the application is not good, then the complications can extend to the uterus also. If the if you
Rare
haven't
cases
seen
of
that
even uterine rupture cases have been found. There can be shock, sepsis if proper asepsis is not maintained, and delayed long-term like chronic backache and genital prolapse,
Stress
stress
incontinence.
incontinence. So now what is failed forceps, Dr. Namita?
Sir, a failed forceps is diagnosed if the fetal head does not descend after the two pull. Sir, with each pull, the head should descend. If the head is not descending, then it is considered as a failed forceps. And if the fetus is undelivered after the three pulls with and there is no descent, then also it is considered as failed forceps.
Why?
And when we should
Yes.
always have we should always pull during the full maternal contraction when there is maternal contraction.
Yes, and possible causes of failed can be undiagnosed CPD, incomplete cervical dilatation, and wrong diagnosis of the position or even incorrect application.
Incorrect applications.
And now, Dr. Namita, why still people are using vacuum and they are scared about the forceps? What are the things which has made forceps unpopular than the vacuum, ma'am?
Sir, basically, the maternal trauma is much more in forceps as compared to that of vacuum, and the trauma sometimes extend to a higher degree. For example, there is anal sphincter injury, which can be deleterious in next pregnancy also, and can lead to some long-term defects. And that is the main reason some people after hearing the forceps complications of forceps don't want to have forceps application. And also there is injury to the fetal head. There can be fracture of the skull bone if not properly applied, fetal skull bone. So these are the conditions, and after this much trauma, there are chances of medical legal implications.
And there is a perception that vacuum is more safer than
Yes, it is more safer because the trauma to mother is less. And after 24 hours of the delivery, also patient is also having less complaint and values as compared to that of forceps.
So there are decreased number of programs that actively train the use of the forceps. The use of any instrument should be based on clinical circumstances and experience of that operator. That is very important. Anytime. And as you are said rightly, regional anesthesia is not required for vacuum. The ventouse is not occupying space beside the head. So even 8-9 centimeter we can apply, and less compression forces, less injury to the head. So now you are doing this procedure. Vacuum extraction was attempted for prolonged second stage. After 3 pulls, there is no descent and 2 cup detachment have occurred. What next? Can I use a forceps now?
No, sir. There should not
we
be
will
a
no
sequential
forceps.
use of
cesarean section.
instrument.
Plain cesarean
Any
section.
instrument failure is a failure.
Yes.
We will not take for
Go for
subsequent.
cesarean section.
Right. So I'm not supposed to, once I have failed forceps, I go to vacuum, or I have
No
failed vacuum,
sequential
I should not go
instrumentation
to
should be done.
So
Yes.
yes. So
Sorry to interrupt, sir.
Yes, ma'am. Yes,
Sometimes,
Dr. Sadhana, ma'am.
it happens, sir.
Yes, Dr. Sadhana, madam. She's not audible.
Our network is very
Gone, I
shaky.
suppose. Yeah.
It's
So
not
preparation for LSCS, no place for
Out the baby by forceps. Yeah, sometimes it happens, sir, ki with 2 pushes or 3 attempts, head is so low in the pelvic cavity. We have to assess the case, and in very rare cases, we can apply forceps. But in practical cases, as the sir has told, no, if there is failed instrument, then we have to go to the cesarean.
Because the studies, Dr. Sadhana, madam, which has been shown that sequential use of these instruments, there is a likelihood of adverse maternal and neonatal outcome more than the relative risk of each complication. So it is always
Yes, sir. Yes, sir.
avoidable. Now,
Yeah.
now this is the last case. Para 3 living 3 with 41 weeks of gestation, referred from PSC with leaking more than 12 hours with prolonged second stage. On examination, pulse is 100, BP is 120/80, per abdomen full term, LOA, FSH 180 per minute, contraction of 2 to 3 in 10 minutes, lasting for 40 to 60 seconds. PV, she is fully dilated, fully effaced, vertex 3+ station, caput is present. We have applied forceps, baby of 3.7 kg delivered, cried well, handed over to pediatrician. But the problem is patient started bleeding. So now, Dr. Sadhna, can you just explain what can be a complication for this?
Sir, for any instrumental delivery, after we finish the delivery, we have to properly examine our patient in proper light. And once again, we have to catheterize the bladder, and we have to examine whole of the vagina and cervix for any extension of episiotomy or any vaginal tear or even lacerations, cervical tears extending up to broad ligament, causing broad ligament hematoma, and even in such kind of instrumental delivery, we have to think about the atonic PPH and other precipitating causes like tissue that is atonic pH, and thrombin, like bleeding disorder of the mother, etc.
So you are going to see whether the blood is red bright blood or a black blood. So red bright can be a traumatic. Others we have to see for a atonic PPH. So rightly said by Dr. Sadhna, after every instrumented delivery, vaginal, cervical exploration is must. Proper examination is to be done. Even you do a PR examination post-delivery, monitor this patient for at least 4 hours so that you are going to save this life, because the golden hour is very important for PPH. Assisted birth should be performed by an operator who has the good knowledge, skills and experience necessary to assess the women, complete the procedure and manage any complication that arise. Advise obstetric trainees to achieve expertise in spontaneous vaginal birth prior to commencing training in assisted deliveries. Documentation for assisted vaginal birth should include detailed information, assessment, decision-making and conduct of the procedure, a plan for postnatal care, and sufficient information for counseling in relation to subsequent pregnancies. Paired cord blood samples should be processed and recorded following all the attempts at assisted vaginal births. Adverse outcome including failed vaginal birth, major hemorrhage, shoulder dystocia, and significant neonatal complication should trigger an incident report as a part of effective risk management procedure. You should have regular audits in your hospital so that you know what you are doing, how you are progressing. The childbirth experience is a significant event of great psychological importance in women's life. It is said that the experience of childbirth forever shapes women's thoughts of themselves and her perception of childbirth. Now I'll come to each one, starting from Dr. Nivedita.
One doubt, sir.
Yes,
Sorry to interrupt. So, paired cord blood sample, could you please clarify this little?
So whenever you are going to do a scalp blood pH, for that you need to know whether any birth asphyxia, then that is very important for medical purposes. So
What
now
is
coming
paired
to the
cord blood sample? So, paired cord blood sample processing blood samples.
Yeah,
Paired cord blood. Just talking about cord blood. Paired
yes,
cord
cord
blood.
blood, not paired, ma'am. Yeah. So now these are the patients where you need to look into the assessment of this patient is very important. Now, Dr. Santwan Sharan, one word from you about the instrumental delivery in your clinical practice. Just take home message. And please
So
don't
if
repeat this.
we should give a genuine and judicious try to the patient if she is
Judicious.
going into labor. and if the conditions are suitable and if it is within our competence and skill, we should give a try for delivery. But finally, the outcome of mother and baby is most important.
Dr. Rina.
The most important thing is good assessment of the pelvis, so that at least if this in the second stage, in the late second stage, when we are going for instrumental delivery, there at that time we should not be suffering, we should not be diagnosing CPD, and so that our instrumental delivery is successful.
Dr. Namita.
Sir, I just want to repeat what sir has said. The judicious use of instrument should be done. It should be done on a double OT setup basis, and it should be done by a well-selected and skilled obstetrician. And we must, it should be done in order to avoid avoidable cesarean section, but with good outcome. So I think so that is
Thank
the
you so
most.
much. Dr. Dipali.
Yes, if the patient has gone successfully for the obstetric vaginal birth, the subsequent pregnancy, there is a 80% chance of vaginal delivery. So it is again, it is an important and it is a
Advantage for them.
advantage.
Dr.
I guess.
Sadhna Rishabh.
Sir, obstetricians should know these instrumental deliveries. Sometime be met with such type of complications such that after full dilatation in multigravida, when we have sudden cord prolapse, how much of our nursing home has the sitting anesthetist and sitting pediatrician? So in such case of such complications, we have very little time. These instrumental deliveries can save baby.
Yes, ma'am. Dr. Shruti Prabha. Dr. Shruti.
Sorry, my call.
I just want to say that the case selection is very important. Case selection is very important, and also the counseling and the consent part of from the party side, because after all, we have to ensure the safety of the patient, and as well as we have to secure ourselves also. So case selection and expertise are the main part, and the new obstetricians should be trained so that this very good art through generations.
Dr. Saini. Unmute, please.
Julie, one thing I can say that with judicial use of instrument, so that we can with proper consent, so that we can get a good outcome. Outcome is good.
Dr. Sutapa.
The patient should it should be used judiciously. Case selection is very important, and when the situation arises, patient must be counseled, and it is important to counsel them beforehand. And it should be done in a double setup. When there is a facility for immediate cesarean section, and after the delivery we have to look for the fetal complications or maternal complications if any, and it has to be taken care of. And then after that the patient must be informed about the situation, why it was needed. And also cord blood sampling is a very important thing, because to help us from future litigations.
Dr. Barnwal has left. Okay, everybody has talked about this. I think a partogram is very important to know whether this patient is progressing well, whether she's going to deliver vaginally or not. That is very important. Secondly, for us, consent is very important for any time you are going to take a operative vaginal delivery consent. Thirdly, what I mean is auditing of yourself. How many patients you have delivered vaginally and how many have benefited with operative vaginal delivery? You should have a data of your own, hospital for 6 months or 1 year, and auditing is very important. And fourthly, the pediatrician should be standby whenever you are going to do a operative vaginal delivery. And lastly, I request everyone to have a litigation-free practice. That is what is very important. Anytime, don't be overzealous. Don't try heroics in the practice. Wherever you feel like somebody was saying, I use only outlet forceps. That's fine. You have decided for yourself what expert you are, and that is what is very important. Everybody might have expertise in outlet, try only outlet. If you're expert in mid pelvis, try mid pelvis. But otherwise, don't try heroics, because these are the patients who will get us into trouble, and we can go to courts for these patients. So litigation free practice is very important, and rightly said by Dr. Dr. Pillai, that by sir, that is very important for us to have a setup ready, a practice, and you should be expert enough. And for PG student, it's very important to learn this dying art, which is there in their medical colleges, because tertiary care centers and medical colleges are the one where a lot of operative vaginal delivery is still done. So cesarean is very simple because of the good antibiotic, good protocols, and good practices. Cesarean is very simple, but this art has to be there because India is the global leader in the population. So we should have this art going ahead in the future centuries also. I thank all my panelists, Dr. Santwana ma'am, Dr. Reena madam, Dr. Namita ma'am, Dr. Saini, Dr. Sadhna madam, Dr. Shruti madam, Dr. Dipali Prasad ma'am, Dr. Sutapa Sid, and I can see Dr. Pragya Mishra, who is there, Dr. Suman Sinha ma'am, who is there till last moment to attend this panel also. I thank Dr. Monica Umbardhan, who is the chairperson of the PAC, Dr. Satabdi, who is the coordinator for this webinar. I'm really thankful to these two people for arranging everything, right from selecting good people, and it was really nice academic discussion. The art of forceps and vacuum has to go ahead to the next generation. I thank everyone from bottom of heart. Thank you so much.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you
Sir,
for
we
the
can see
wonderful
Suman ma'am and Pragya ma'am there if they have to add something.
Yes, Dr. Suman Sinha ma'am. No, she's not there. Dr. Satabdi for vote of thanks.
Yeah, thank you, sir. Sir, Monica has joined. Monica, over to you.
So Monica, welcome. Vote of thanks.
Thank you, sir, for allowing me and Shatabdi to coordinate this webinar, and it is an honor to work with you. We also thank Dr. Pragya Mishra, Dr. Sita Pal, and Dr. Suman Sinha madam for gracing the inauguration. All the Northeast societies who have joined today, the president and the secretaries, our chairpersons, Dr. Rafizur sir, Dr. Priyankur, and Dr. Deepanita Sen, our esteemed faculty, Dr. Murlidhar Pai sir, for such an elaborate talk on how to reduce the complications of cesarean section and increase the incidence of use of instruments in the vaginal delivery. And the icing on the cake was the panel discussion, where our panelists have given excellent inputs and great take-home messages for all the delegates. We also thank Corona for the academic and technical help for this. Thank you, Shatabdi, for arranging everything for the panel discussion, right from the faculties and coordinating with them. Thank you so much. We welcome you to the next ECHO after 15 days with the South Zone. So please stay tuned and help Dr. Kalyan sir to achieve greater heights in Foxy. So requesting everybody to please vote and support his endeavors in Foxy.
Thank you, ma'am. Dr. Pragya ma'am, welcome.
I must say, this is the first echo which in the series which I am attending, and it was fantastic, Dr. Kalyan. I mean, with the lecture, I mean, Dr. Murlidhar Pai's lecture, we anticipate it's going to be very good, and the panel was also very good. You know, I just wanted, someone said if I could, I was there, I was just examining one patient, so I was listening to you. Like, you know, because I've worked for 5 years in the UK, and there, you know, like one extra cesarean which people thought was not needed, you would have a meeting and a discussion, a meet, that why this cesarean, why did the registrar or the SHO did this cesarean section. So, you know, it's like that, how they want to reduce
Auditing.
their... Yes, the cesarean section rates, you know, and really we had to give explanations, this, you know, that's the reason why I actually went ahead and did this cesarean section. But sometimes, and I also faced situations there when, because, when I was there, the studies were going on regarding a routine episiotomy, I mean, giving to every patient. That study was also published, whether routine episiotomy can prevent 3rd and 4th degree perineal tears, which they said no. Then at that time, they were telling us, you don't give elective episiotomy. But then after deliveries and all that, women had terrible perineal tears. I mean, 2nd degree I'm talking about, 1st and 2nd degree. And I still remember being called, in the middle of the night, telling me to suture, and which actually looked like a jigsaw puzzle for me. So sometimes, when we are doing, we really have to protect the perineum also. When you are doing want-tos delivery, so really we need to protect the perineum. Otherwise, they can have terrible tears. I'm not saying 3rd and 4th, but even 1st and 2nd degree tears can be quite bad, and can take time for healing. So I think that's also very important. But the West, especially in UK because it's conservative and it really wants to reduce its C-section rate. So there, I mean, this was a problem, because they did have a lot of 1st and 2nd degree tears if they did not give elective episiotomy in these cases. So I think that also we have to be very conscious about. But definitely, I feel instrumental delivery is sort of becoming a dying art, which I think stalwarts now should help in resurging the art of instrumental delivery, so that we can reduce the incidence of cesarean section. That's what I want to say.
Thank you, Dr. Pragya ma'am, for your words of wisdom. That is very.
Dr. Sadhna was saying that yes, sometimes fully dilated, and and a patient who can actually deliver vaginally with little bit of help, why straight away take her for a C-section? So I think it's something which we should not let it die. The art of instrumental delivery. I think that would be my last words. Thank you.
And I was expecting Dr. Simi Kumari from Patna, because she's an IVF consultant, to listen to her answers. But I think she was not there today because she was an IVF consultant. So many IVF people do directly cesarean section for many patients like multi also. So that is another question of debate, whether to do a cesarean for all in IVF cases also. I thank everyone for this wonderful academic discussion, and see you for the next Eco webinar series with the South Zone. Thank you so much. And thank you, Dr. Monica and Dr. Shatabdi, and our chief guest, Dr. Pragya Mishra Chaudhary, madam. Thank you so much.
Thank you, everyone.
Thank
Good
you,
night.
sir.
Thank you. Thank you, everyone.
Good night.
Thank you, everyone. Thank you, ma'am. Thank you,
Good
everyone.
night.
Good night, sir.